Hi, welcome to Dental XP. I'm Connie Driscoll. I'm a periodontist at Georgia Regents University, College of Dental Medicine, Augusta, Georgia. And today we're going to be talking about my very favorite topic in the entire world, and that's non-surgical therapy. Now, you may wonder what a periodontist is doing talking about non-surgical therapy. Well, I was a hygienist for 16 years before I was inspired to go back to dental school so that I could do the periodontal surgery. But what I want to talk to you today about how important it is that you have the basic good infrastructure for periodontal therapy. And that all starts with the non-surgical preparation of the mouth. Now, I'm not going to tell you that you never do surgery. That's not the message today. But the message is that you do non-surgical therapy the absolute best that you can, and then, if surgery is needed, we'll follow up with that later. So let's get started. I do need to give you some disclosures. I have been a researcher all my life, and I have worked with many of these lovely companies that you see on the screen, and have done a lot of clinical research over the years. But this presentation, if I do mention some specific products, it's because that's what I use in my own practice. And the presentation is geared very much towards the literature. Not that I'm going to give you a bunch of dry, boring slides to look at. We'll try to make this very clinically applicable. But I do want you to know that most everything I say is going to be based on the literature. And if it's just my personal opinion, I absolutely will let you know that. So, I've picked this title of The Dilemma of the 6mm Pocket, the 6mm bleeding pocket, because that's what we have to deal with when our patients walk through the door. Yeah, they may have 7s and 8s here and there, and they may have lots of 5s, but it's that middle ground of the 6mm pocket that's bleeding that we think we can make a big difference in the initial preparation of that patient. And if we can turn those into 4mm pockets that don't bleed, then, hey, we've got a winner. So, can you do that with scaling and root cleaning? And I also should mention I'm going to be using the term scaling and root cleaning in total switching back and forth between that and the term periodontal debridement, because periodontal debridement is really the term that we most all use now instead of just scaling and root cleaning. So, is it predictable? Well, I hope by the end of this presentation that you'll find out that it is. Now, I'm not going to insult you by going back through the whole etiology of periodontal disease. I know that you know that it's an inflammatory response to microbial plaque and calculus, and that controlling that calculus and plaque and controlling that inflammatory response is all part of what we have to do as part of the therapy. Now, it doesn't take anybody very bright to look at this slide and figure out that there's a lot of inflammation going on here, right? So, what are you going to do about it? You know, you've got plaque, you've got calculus, you've got bleeding, you've got smuts pyorrhea, we used to call it. And it's obvious that there's going to have to be some mechanical debridement of this site in order to get rid of all that stuff so that the body can actually heal itself. Now, we can't always do that just by scaling and root cleaning. So toward the end of this presentation, we'll touch a little bit on when you need to use antibiotics or not, and some of the new instruments that we have out there that will be available to us before too long that will really enhance our ability to get that plaque and calculus off the teeth. So, what are part of the reason that we do periodontal therapy? Well, obviously, it's because we want to be able to save teeth, right? And why do we lose teeth? Well, there are a lot of risk indicators that if you have any of these that you see on the screen here, age, if you're male, sorry guys, if you smoke, if you're not very good at your home care, if you're hypertensive, if you're diabetic, if you have arthritis, if you have thin tissue types and really crowded teeth, and if you've never really been to a dentist on a regular basis, all those things are going to make you much more susceptible to losing teeth from periodontal disease. And if you look at the data, and I promise I won't show you too many big slides like this, but if you look at some of the actual data that's out there for you to read, it's obvious that if you look at the column on the right here, that you can lose as much as 1/3 of a tooth a year if you don't have periodontal therapy. Well, if you get as old as me, if I had lost 1/3 of a tooth every year, I would have lost most of the teeth in my mouth by now. Okay? So the idea is that periodontal therapy will help us maintain the teeth of our patients. Now, how do we do that? Well, we do that partly by starting out with the basics, scaling and root planing or debridement, periodontal debridement. That obviously always has to be coupled with very intense oral hygiene instructions. Then we go to the next areas, and in the last few years, we have some new tools which we can add to the non-surgical treatment, such things as low-dose antibiotics that change the host response of the patient so that they don't respond to the inflammatory mediators like you would otherwise. And we also have local drug delivery products where you can put high concentration of antibiotics or antiseptics into the pocket after you scaled it and get an enhanced healing. And we're not going to talk about that too much today, but just at that point, then you have to make the decision. Are you done? Or do you have to go on to some surgical therapy? And if you do, and in most advanced cases, it's a combination of both. You do some preparation, non-surgical, and then there are going to be areas, particularly in the multi-rooted teeth, where you're going to actually probably end up doing surgery. So after surgery, it's extraordinarily important that you put people on maintenance. Now, here's where the rub comes in. You're not done because periodontal disease is a chronic disease. And if you don't measure those pockets and look at the attachment loss and check the mobility and all the things that you have to do over time, when you do the recall or the maintenance on that patient, if you find places that are failing, then you've got to circle right back down to where you were at the beginning and start all over again and retreat those pockets. And I think if we have one mistake that most general dentists and practitioners and hygienists make is that you're reluctant to tell a patient that they need retreatment. So retreatment's not a bad thing, and believe me, I've got some patients that have been mine for 25 years now, and I've reoperated the same site 2 and 3 times sometimes in difficult furcation areas. So what's better? Lose the tooth because you've neglected it? Because you're afraid to tell the patient they need more surgery? Or to get them back into the loop and start back over and go through your whole process again? So keep that in your mind as we go through. So, can we do this with scaling root planing? So let's look at some of the things we're going to look at quickly first. Is the kind of instrumentation that you should use, how do you know when you're done, and the long-term effects. So, we know, there is no doubt in the literature, there are thousands of articles that show that mechanically removing the plaque and calculus from the teeth actually does reduce the inflammation. And if you can get the pockets, the probing depths, down to something that's 5 or less that don't bleed, then it's time to put that patient on maintenance for a while and see how they do. Because you'll be surprised that some patients, if you put them on maintenance for a year, they may look better than you would have ever expected. So don't get in too big a hurry to cut on those gums, because you need to give the body a chance to heal. And once you get rid of the bleeding on probing, there's a pretty good chance that you've also gotten rid of the active inflammation and infection. So bleeding on probing is a pretty good indicator. If you don't have it, it doesn't mean you don't have inflammation. You could be a heavy smoker and that you might not bleed and still have active disease going on. But as a rule, if something bleeds, then you're probably not through treating it yet. Okay? This is a real good example. This lady was a 34-year-old lady, African-American female, who came into my office, and she had bad breath. That's why she was there. And you can tell by the inflammation that she was pretty highly inflamed. What you can't tell from this picture is that she had almost spontaneous bleeding on probing. A lot of suppuration when you probe these areas. These areas were all in the lower anterior and the maxillary area were all 6 to 8, 9 millimeter pockets, and she had class 2 mobility on all of these teeth. 34 years old, okay? So then in your head, you got to be saying, uh-oh, something's going on here. What else is going on? Well, I started taking a really thorough medical history, and guess what? She has to get up in the middle of the night to go pee. She's thirsty all the time. She's got numbness and tingling in her feet and her hands. So I know the red flags are beginning to go off in your head, aren't they? And the red flag is, of course, that this lady is probably an undiagnosed diabetic. So we sent her off to her internist, and she had a blood sugar of 450. Okay? Now, so she comes back in, and we do what I'll describe in a little bit as a thorough ultrasonic bactericidal debridement. And this will include using povidone iodine in the ultrasonic, and I'll show you some video clips of this in a little bit. But just within this one full mouth debridement, we went from what you see on this side of the screen to what you see on this side. You can see there's still some inflammation here, but you can see that there's a tremendous amount of resolution of some of this redness and swelling. And this is only after 1 2-hour session in the chair with me. Now, this lady ended up going through lots of other therapy. But one of the things, and we'll talk about this again in a little bit, she was very unhappy because she didn't like the extra space that she could see between her teeth now. She didn't like the recession. And as you know, when you get rid of the swelling and the inflammation, you're going to have some recession. So that's another thing. You've got to have that conversation with your patient before you ever lay a scaler on them, because almost always you're going to have some recession, some tightening of the gum and pulling back of the tissue, and you may end up with some spaces in between the teeth and some more tooth exposed. You see, look at the difference between this tooth in this picture and this tooth over here. I mean, that's a lot of tooth that got exposed just from one session of instrumentation. So we'll talk a little bit more about recession, and I'll show you some slides on how much you can expect as usual when you do these types of things. Now, in this case, the slide up here says power equals manual. It doesn't matter whether you use hand instruments or whether you use ultrasonic or power-driven scalers. It doesn't matter what kind of scaler you use. There have been lots of studies, and it's all in the hands of the operator, okay? It really doesn't matter. Whatever floats your boat, whatever makes you happy, that's all you need to do. Power-driven scalers are equivalent to hand scaling, so you have your absolute clinician's choice of whichever you use. Now, I'll try to probably give you some hints as to why I personally think power-driven scaling needs to be included in the equation. But your idea is that you're trying to get rid of all this plaque and calculus on the root surface. And so if you look again at the literature, power-driven scalers are just as good as getting plaque and calculus off as hand scalers. But what you have the advantage of with the power-driven scaler, and you'll see this in the video in a little bit, is that you can put some antimicrobials in there, which may also have an additional effect, flushing out the pocket with something that will also kill the bacteria on contact. Now, this is just a couple of notes about a study that was done by a fellow periodontist out in Tempe, Arizona, named Mick Dragoo. And Mick did a very interesting study. When the new slimline ultrasonic tips, the Cavitron tips, came out years ago in the early 90s, Mick was convinced that these probably were pretty good. And he thought, in his clinical's mind that the instruments probably could get to the base of the pocket better than a hand scaler. So he invited 10 of his best dental hygienists and dentists into his office. And they brought their patients, and they worked on teeth that he knew were treatment planned for extraction. And so they came in, and he told them, bring your favorite, hand scalers and work as long as you want. And then when you get through with one half of the mouth where there's a tooth or two that needs to be extracted, then come over on the other side and try these new ultrasonic tips, these little thin tips. Then he extracted the teeth, but before he extracted them, he made a little mark right where the gum line was, so he could see what the attachment penetration was of the tooth into the pocket. So you see this probe in here is 9 millimeters. So this is the periodontal ligament that's been stained dark. This is the residual plaque and calculus. You can see that that's a little bit red, so that means the erythrocin dye has stained it. And then he measured to see how far the hand instruments versus the ultrasonic instruments could penetrate the pocket. And guess what? The ultrasonic tips actually were able to penetrate a little bit better. So that's the reason that we think that the ultrasonics probably need to be there. And just to sort of back up a minute, you remember from your school days that when you have inflammation in the pocket, that the probe is going to pass right through the epithelial attachment. It's going to pass right through even the connective tissue. It might even pass through some really porous bone. And so when you measure these pockets and you have a lot of inflammation, you may actually be probing right through the attachment all the way to bone. So that once you get rid of the inflammation, you may gain a couple of millimeters or so of attachment just because everything is tightened back up and gotten more healthy, and the probe doesn't penetrate as far. So that helps explain why you can get some fairly dramatic differences post-operatively just by getting rid of the inflammation. And I like this slide because this is from one of my scaredy cat patients, big, tall, 6'7" policeman who would, faint every time he looked at me when he'd come into the office. But I finally got to where he was a really good patient, and so I talked him into letting me take this, put this ultrasonic tip into this deep 11 millimeter pocket on the distal of his molar, and then walk him into the other room and take a picture with the radiograph with the X-ray machine. And you can see exactly what I'm talking about. This is you can see here's the CEJ up here. So this is like 11 millimeter pocket. But it's also an intrabony pocket. So you can see this kind of gray shadow. And when you put that instrument back there where it's really inflamed, it actually is going through the epithelial attachment, the clinical attachment, and actually into bone. So, but this is where you want to be, because right at that very last little bit of attachment before you get to where the ligament is attached to the tooth is where that last little bit of plaque and calculus are. So that leading edge of plaque and calculus is what you've got to get off. So obviously this patient has to be numb to do that, and you can't be a sissy about it. You really have to get in there. And you'll see it in the video in a minute. The other reason that I particularly prefer power-driven scalers is because they also are able to get into all the root grooves and flutes. And some of the hardest places to clean are like this happens to be a premolar, an upper premolar. It's turned upside down here. But, that little groove that's on the mesial of an upper premolar, that's an area that's extraordinarily hard to clean. And with this ultrasonic tip, you can get in there much easier than you can with a hand instrument. Same thing with furcations. This is a tooth turned upside down and has calculus all in the furcation, the top of furcation. And there have been lots of studies to show that in the class 2 and 3 furcations, that you can actually do a better job with power-driven scalers than you can with hand instruments. It's partly just because of the physical size. So, a scaler is going to be at least a 1.5 millimeters or so wide. Some of these tips can be as little as 1 millimeter wide. So just the access to those areas is improved. And this is a little study that I did, and you do get a smoother root with the ultrasonic than you can with a hand scaler. This is a little study I did many years ago. It instrumented the teeth with either a hand instrument, as you see in the top picture, or an ultrasonic scaler on the bottom. And if you blow that up and look at under after it's been coated with the material, so you can look at it under a scanning electron microscope, this is the residual calculus on the tooth. So that would be, this is the part you're looking at here. That would be blown up higher magnification. That's the calculus that we intentionally didn't scale. Here's the part of the root that we tried to scale very carefully with a hand instrument. And you can see we not only didn't get all the calculus off, but we also left a smear layer. And the smear layer, we think, we know, interferes with the reattachment of the epithelial attachment to the tooth surface. With the ultrasonic scaling, you can see that it's a much cleaner looking area. And when you blow it up high, you can see it's very, very smooth with no stripes or smear layer. So again, this particular bias of mine, based on my own research, is that you leave a cleaner root surface without a smear layer when you end with an ultrasonic clearing. That's not to say you can't use hand scalers, but after you finish the hand scaling, I always go back and finish with an ultrasonic. So keep that in mind, because that way you don't leave that smear layer behind. Now, you don't necessarily have to strip all the cementum off a tooth to get it clean now. Now, years ago, we used to, think that you had to do this. So let me just tell you what you're seeing on this picture. This is actually a tooth cut longitudinally. This is actually calculus embedded into the cementum. So this is the cementum, this is the dentin, and this is actually the pocket epithelium. So this tooth's been taken out with the pocket attached to it. The reason it's bright green is because it's been dyed with an immunofluorescent dye that picks up Porphyromonas gingivalis, which, as you know, is one of the most invasive and significant bacteria, one of the top 3 associated with periodontal disease. And as you can see in this photomicrograph, this is from my research many years ago in the 80s, that not only is the Porphyromonas gingivalis invading the calculus, and you can see it here even down on the root where the calculus is thin. So the calculus has invaded the cementum, but it's also invaded the epithelium that's next to that calculus. So this is proof principle that these bacteria, just by cleaning the root, you're not going to get all of this stuff out, because it's also embedded into the surface of the epithelium that's next to the tooth in the pocket. So this is one of the reasons why in a minute, when we show you some ideas about using povidone iodine, this is the reason that I use povidone iodine in the lavage with the ultrasonic, is because I'm aiming to decontaminate and disinfect this pocket epithelium at the same time I'm cleaning this infected calculus and cementum off the root. So there are all kinds of instruments out there, and it doesn't matter. As I said, there's really no direct comparisons in the literature that there's one ultrasonic that's any better than the other, blah, blah, blah. But you do if you don't have one already, you need a new ultrasonic, I would definitely recommend that you get one that has the ability to have an antimicrobial in the lavage system, okay, like this particular model does here. And the reason I say that is because there are some evidence that shows that you can get a slightly better pocket depth reduction, slightly less bleeding, and so forth if you use either chlorhexidine or povidone iodine in the lavage. Now, I just read an article the other day, and I don't have it on these slides, but povidone iodine does have a very good antiseptic property. It has the ability to kill bacteria on contact, yeast, viruses, and it also has some substantivity. Now, we all know that chlorhexidine has substantivity, but povidone iodine does as well. And the reason it does is because of the povidone part, the polymer part. Now, just as an aside, you can get the expensive stuff called betadine, which is what you're used to hearing used in the operating room to scrub your hands and to swab the mouth out, because it's a very good topical antimicrobial antiseptic. But you can also go to the grocery store or the drugstore and get the same kind of exact same product, the generic form, for about a third of the cost. Now, as I said, it's an outstanding antimicrobial. It's productive against both gram-positive and negative fungus and virus, has substantivity, and the way that it's been used, and the way I've used it for 30 years, is to dilute it 3 parts of water to 1 part of povidone iodine. So the povidone comes in a bottle that's labeled 10%. But actually, the povidone is 9/10 of that, and the iodine's only 1/10. But you still want to dilute it 3 parts to 1. 3 parts water to 1 part iodine. And you will still have substantivity in the action. Now, there are a few people you can't use this technique with. People who know they're allergic to iodine. There are not that many people in the world, but once in a while you run into a patient who is allergic to shellfish, especially. If they tell you they're allergic to shellfish before you use povidone, you need to make sure that you are that you use the alternative, which would be chlorhexidine. And if they're childbearing capacity, then your potential might be that the literature out there says that women who are pregnant should not use things like iodine douche. Well, the oral cavity is very porous and has mucous membranes, not unlike the vaginal area. So with that information, you probably should not use povidone iodine in your ultrasonic if a patient is of childbearing age, because there is some evidence that there could be some harm to the fetus. But given those two things, if you look at just the data that we've gone over quickly about the difference between a curette and a power-driven scaler, probably the biggest difference is that the power-driven scaler will, save you a little time, and that in most cases, most people use both, including myself. Now, it does disrupt the biofilm. We've talked about that already. And we've talked about that some pathogens can penetrate into the tissues, and we talked about all of those. And if you don't get rid of all those pathogens that are embedded even in the root of the tooth, then that's where you may want to think about a systemic antibiotic at some point, or local drug delivery that would actually penetrate those dental tubules. So as you can see in this photomicrograph, all these black spots and these little streaks, those are all viable bacteria that have gone from that infected root surface that's down in the pocket right towards the pulp. So have you ever thought about how many patients who have periodontal disease also end up having to have a lot of root canals? Well, this is part of the reason, because they end up with exposed root surfaces that have plaque on them, and that plaque can actually, the bacteria can actually penetrate all the way to the pulp. And that's been shown in some beautiful studies done in Belgium over the years. So this may also be part of the reason why periodontal disease is such a chronic disease. It's really hard to totally disinfect the pocket and the tooth. So that's the reason why, that, in my belief, the combination of mechanical debridement along with some sort of chemotherapeutic products, either sustained release like local drug delivery products, occasionally systemic antibiotics, or things like povidone iodine in the lavage can make a difference. Now, we also know that besides in the pocket area, you have other areas outside of the pocket that harbor all these same pathogens. And this particular study, not to go over it too thoroughly, but just to show you that if you look at the number of cells, the total mean bacteria count in actinomycetum comitans, they've all got new names now, Porphyromonas gingivalis, T. denticola, the spirochetes. This is before scaling. This is after scaling, a month afterwards. So it's like, really? You mean I did all this work and a month later they're already coming back? The answer is yes, they are. So, if you look at some of the studies that have been done, you see this little bright, this is a spirochete that's actually in the epithelial cell. And so they invade in the soft tissues in your cheek, the crevices in your tongue, in your tonsils. Those guys get everywhere. So that's the reason why an antimicrobial mouth rinse after therapy also makes sense, because you want to keep down this level of reinfection. And so if you look at it after periodontal therapy, as I said, look at the repopulation already even at 0. If you look at the 0 number here, you can see even at the time that you finish your scaling, you haven't gotten rid of all the bacteria. At 3 months, you can see it's coming back. By 6 months, it's coming back pretty strong. So that's another reason why maintenance, regular maintenance every 3 months for most perio patients is really important. And I love this slide because it kind of reminds me of some of the science fiction movies that you see. It looks like the worms are crawling out of the craters in the earth, doesn't it? But this is just another depiction of this nice work that was done, as I said, in overseas, where you can actually see these are filamentous organisms coming right out of the dental tubule. This one you saw earlier, that's the vertical section of it. This would be a cross section of that dental tubule. See all those little white buttons in there? Those are actually viable bacteria. They're making their way right to the pulp. So you can see that it's not easy. It's not even easy to get plaque off the teeth. You'd think, oh, that's soft stuff. You ought to be able to just, get that out really easy. Well, unfortunately, it's not. And guess what? Biofilm, or dental plaque, not only has a hydrocalyx around it, so it has a little polymer coating that will keep antimicrobials from penetrating in here. And these things are like 500 cell thick. So when you scrape some plaque out of a pocket and you see it on the end of your curette, you're just getting started, because you can't possibly remove it all with an instrument. you can't possibly remove it all just by irrigating things down in there either, because this stuff, Mother Nature is really smart. She designed plaque so that it has these little channels so that it can be 500 cell thick. So how do the bacteria that's at the bottom of that pile get fed? Well, they have these little nutrient channels. And so you have to physically remove this plaque in order to kill it, because you can't just put stuff down there and expect it to penetrate through this hydrocalyx and through 500 cell layers of thickness. So Mother Nature is pretty smart. She's figured out a lot of ways. Now, we do know that if you are really good at brushing your teeth, and this was studies done by Dr. Hapagy years ago, that if you brush your teeth really, really well, and you've done all the cleaning, you got all the plaque and calculus off, then it takes about 3 months for it to reform subgingivally. But guess what? If you're not very good at getting the plaque and calculus off, then it starts reforming within weeks. So the chronic reinfection of the pocket is a problem.